Thank you very much. Good morning, everyone. I've never enjoyed an outbreak investigations as I did last year at the Playboy Mansion. It was both exciting and stimulating at the same time. The exciting thing is, as a matter of fact, I mean, the way we found out about it was when one of the attendees went back to Germany and updated his Facebook status, and then that really started a discussion around the people who were in the same event, trying to sort of be more like CSI Playboy Mansions. I was at this place, but I wasn't there. I ate this food, but I didn't eat that, and it was quite interesting. What was more interesting is that was the very first leading indicator for us that there was actually an event that happened, and this is pretty much true for a lot of the things that we deal with. It's not the signal that you get from the healthcare system. Is oftentimes the rumor that starts, and if it's early enough, you might actually find that needle in a haystack. But what's more interesting is how we look this and tie this to actually what's happening in the healthcare system and how the healthcare utilization can help us whether to refute or confirm that there's an actual event is going on. As simple as something like very, very small scale like this, or something even more widely distributed as in pandemics and whatnot. Just in general, these are the two things when we in our businesses. What we're trying to do is when an event happens, trying to kind of minimize the time to when we detect that event, and also what is the time it takes for us from when that event has happened is to actually educate the public about it and communicate it to the rest of the population. And that's sort of the challenge that we're all in, and sort of like what's exciting about this field. But also, if you try to find something early, you can actually do something about it, especially when you have limited resources, as experienced in the H1N1 pandemic. About 10 years ago or 14 years ago, it used to take us about almost 6 months to find out about an event. That's a very, very long time. And with social media and a lot of the digital disease detection and more adoption of cell phones and people actually adopting electronic health records in many places around the world, we're able now to bring it down to about 20 days. Which is quite significant. And this is, for example, what happened with H1N1. Within about a week and a half, 2 weeks, we were able to sort of really hone down on what it is, where it is, and sort of like put our parameters around those. But that didn't prevent that, to see school-age kids dying in emergency rooms. And this is one of the most disheartening things that we had to deal with during the first wave of H1N1, is we didn't know what's going on in emergency rooms. We didn't have any system that connected these emergency rooms together, so that way you can really know which population sector of the population is affected most. What are they dying from? Are they staying in emergency rooms? Are they being sent home? Are they getting admitted? So we went to and venture out is about, okay, well, I mean, we're in the middle of pandemic right now. So what we tried to do is kind of look at across the country, work with healthcare providers as well, health departments, and see how can we open the vault. And created a really small platform called the Distribute Project, where sharing aggregate level data about emergency room visits. So it's very, very simple. How many people showed up in the emergency room today that had influenza-like illness, and what is their age category? And within about 2 months, we were able to stand the system and covered about close to 88% of the U.S. population. But learning from that experience really shaped how over the last 2 years we start thinking at CDC and also with all our providers in the healthcare sector and public health departments at local and state level. Is essentially we wanted to rethink about disasters are the worst time to exchange business cards. You really have to kind of prep way beforehand. And so what we tried to do over the last 2 years is rethink all the policies, rethink all the data sharing, take advantage of meaningful use, since there's a population component there. It's especially for stage 1 was optional to share syndromic surveillance data with the public health. Syndromic surveillance is basically, if I show up to emergency room or urgent care center, where's my primary chief complaint? And if initial diagnosis happen by the nurse practitioner or by the clinician or the physician, is be able to also capture that, whether within a day later or something like this, because that can provide us a little bit earlier sort of indicator about what might be facing it, how big it is, which kind of direction it's going from south to east to northwest, and it's affecting this sector of population. It's really more like sort of contained in one area and more severe one ethnic group than another, and so forth. I mean, so it's just kind of give you a little bit of flexibility early on to put your hand on the problem. So we started in building a platform where healthcare providers as well as public health can start sharing that information with one another. That's governed by the community, including the healthcare sector, and also has a flexibility about what you can share and what level you can share the data. For example, you might be able to share with your neighboring jurisdiction at zip code level, but within your jurisdiction you can share patient level data and also have the healthcare provider in the hospital be able to see that data and see how is that contributing to the rest of the population. The very first iteration of this was we tried in Boston and also in Tarrant County, Texas, which is Dallas-Fort Worth, where these people even pushed the envelope further, where now they share the data publicly with the public. So if you're in Tarrant County, you can go on Google Public Explorer and see what happened in your emergency rooms last night with regards to heat wave, respiratory, gastrointestinal, and a few other conditions. So this is the model that we built. It's happened around a program called Biosense. Without going too much into detail about what Biosense is about, we call it Biosense 2.0 because 1.0 didn't work, but also 2.0 because of the collaborative nature. This essentially is the ecosystem that all contributing to this. And the model is really fairly simple. It essentially is anyone who's contributing information or data will have their own sort of what we call a catcher's mitt or a locker. And that's what's depicted here in the green circle. And the data sources they bring, they have full control over and have the relationship with. For example, in this particular example, could be a local health department with the hospitals that are contributing that data or urgent care centers. And that's depicted in the red circles. People don't have to be in this environment. One of the things in public health is resources are really scarce and funding is very little. So attention to IT or information technology or storage or capacity is something that a lot of health departments not even consider a priority, is they might not be able to afford. And we're talking about syndromic surveillance or public health data that's coming out of the healthcare sector. It's almost a tsunami just hitting you. So you really have to sort of prioritize which data you want to select and whatnot. So we built this environment in a cloud infrastructure. We worked with Amazon, where you buy your books, but they have a government section there that we were able to put security controls on that meets the FSMA moderate as well as the CDC controls. And it's offered for free for any public health department in the country to have. So I mean, it's as simple as signing up for an email account with a company. So you just get your email account, and then you have all these services from for example, transport of healthcare data from point A to point B, to transforming that from HL7 to something that you can consume, to also the analytics where you can able to interact with this data or download it and whatnot. So that's really what's happened in that, what we call the locker or that green circle. There are several health departments in the country that are on their own able to sustain their own infrastructure, whatnot, so they'll still be part of this picture. And the way it is really happening around this yellow circle here, which we call the shared space. And this is really where a lot of the interaction happens, is where you can share the data. And data can be shared at the patient level, at the aggregate level, at the county, state, or even region level. And for us, CDC, is the way we can paint that picture for the first time is not through getting all the data coming to CDC, is rather participate in a collaborative environment where people are sharing data with us, and we'll be able to paint that situation awareness picture. This picture depicts also how currently we're working with the vendors community. For example, Epic, Cerner, Kaiser, etc., where it's a lot easier for them to, which you have the largest footprint here in the country for emergency rooms, is to build the interface one time and have one data feed from their store to this environment, but then separate it to all the health jurisdictions. So instead of having to work with every health department in the country, we're enabling them to have very, very little investment on their side, meet the standard for meaningful use, and then be able to provide an environment where they send this information in a secure fashion. So it's been really exciting for a lot of vendors and healthcare providers finding this as a way to meet their demands and also help contribute to the population health picture. Just a sample of some of what we see every single day. I mean, as you see, people touch the healthcare system for a variety of ways. It doesn't have to be infectious diseases. A lot of this is, around cardiovascular illnesses, pregnancy, about injury, environmental, like for example, allergies and whatnot. So you'll be able to actually put your hand on the pulse of the nation just in one place. Share with you just one relationship that we've had around the Super Bowl event. This is where Indiana, New York, and Boston and Massachusetts start sharing data, because all these fans are flying to one place in Indiana, and then they could be bringing things with them, or they can be affected when they go back to their regions. And primarily when you have big events like this, whether it's an Occupy event or something like this, you monitor gastrointestinal and monitor injuries. But we found out there was one news alert, which is another thing where we incorporate social media and news in this platform as well, about a measles case roaming the village, where there was about 150,000 people there potentially could have been infected. Luckily, there's a happy ending to this, is there's quite a bit of herd immunity in the community. A lot of people are immune in this country to this disease. Is that the aftermath wasn't as horrific as we thought it was. But the interesting thing is immediately these now 3 jurisdictions start sharing additional rash illness and extended the period of sharing. And you'll be able to zoom down to that level of where the event is happening. Recently, as you're aware about the heat wave, and this is another thing where also you can share that data, but also subscribe to alerts, so you can set the threshold where you want to see the alerts happening in your jurisdiction and get an alert on your mobile phone, etc. So, and be able to sort of keep track, and you can also separate this by the age of the population, which region you should focus on and whatnot. Another example is about something Lynette alluded to, which is beyond infectious diseases and outbreaks and other things. What are other things in the population that we can really start for the first time take advantage of with this healthcare information exchange that's happening around the country? This particular project was about to monitor what we call the ABCDs. The aspirin therapy, blood pressure, cholesterol, diabetes, and smoke cessation. Primarily, these are the outcomes that, if you can control them, which is, it's really cheap to buy aspirin or monitor your blood pressure, can be not as expensive as some of the most more acute or riskier the diseases out there or conditions. So, and then this is something where you can apply, if you apply an intervention or a prevention, you can actually see within a short period of time the improvement, not just at the individual level, but the entire population. But this is the very first time in the US we're able actually to kind of do this kind of stuff with all the exchanges that happen around the health information. So our first pilot started in Maine, working with the Health Infonet and the Public Health Department there. Initially, we looked at the meaningful use stage 1 44 measures. And then we tried to sort of identify of those 4 or 5 outcomes I just mentioned, the ABCDs, what kind of measures contribute to those. And then worked with the Health Infonet to actually try to start calculate those and then share that at the population level. This is just a high level about what these 13 measures are. Currently the NQF 2728, which is around assessment of tobacco or advice to the patient about how to kind of quit smoking, as well as the NQF 59 and 64, which is around whether bad management of diabetes or good management of diabetes. Next week we're going to start with hypertension and a few others, for example, the body mass index and other things to start monitoring at the population level in real time. The exchange happened between the healthcare, or the HIE, and the public health department through Connect Gateway. So essentially, we set up a gateway in the HIE, another gateway to get this information and share it with public health. And I'll walk you through the steps in a little bit. Something about Health Infonet, if you don't know, it covers about 77% of the population, has an opt-out of 1%, where if a patient opts out, then all their records are deleted. 1% actually is a pretty solid. Other areas in the country could be about 5 or 10%. So so almost we have a full coverage of Maine. That within 5 seconds we get that information at the HIE, and then the calculations happens there. There's quite a bit of mechanics that happens under the hood where you have to generate the continuity care document and then be able from that to derive the meaningful use measures, exactly how the formula is by CMS, and then start the extract process from there. We work with MITRE, who has currently contract with ONC to manage the Pop Health tool. Pop Health tool is essentially a tool that really manages all the measures per rule. So essentially you have the diabetes, the smoke cessation, the blood pressure control, all those measures can be calculated if you feed them. They tell you exactly, here's how to calculate the denominator, here's how you calculate the numerator, and then then you feed the tool with CCD document, converts that to XML, and then you can generate the measures. A lot of this the public health department didn't have to deal with, so we created all this so that way it's very seamless from the EHR to the HIE to the Pop Health tool. The measures are generated, and if you're a physician or provider, you'll be able to actually use that tool to monitor the patient level, so you can see patient X, over time how their diabetes is being controlled or not controlled, and other things. For population health side of this is really we're just interested in the bigger picture, the percent of my population or the incidence of the condition. So we have different utility of it, but it was quite interesting just to kind of do all that in one place. And then to the public health department, all they have to do is really just kind of run the analysis on a simple Excel or something like this, and you can monitor those. This is just a screenshot of the Pop Health tool. We can see the percentages on the left for the different measures. Currently, Pop Health tool also working on customizable measures. So if you have your own measure you want to try to monitor, you can actually do that within the tool itself against the data. And this is how the CMS defines the denominator and numerator. So this is more of a standardized tool that can calculate those measures for population health. Just like to acknowledge our partners in ONC and many, many others that we've been working with over the last 2 years to make this environment available, not just for us. CDC built this environment, but it's really available to anyone in the country. The stage 2, you're going to be required to send certain population health data, so please do consider this environment, because it can help you meet a lot of the meaningful use requirements as we built it, so to meet those. And some of our contractors have been working on this. Thank you.
Thank you, Taha. And I think we have some time for questions from the audience. So we have microphones over here. I welcome you to come up, and in the meantime, I'll throw out a question to both Taha and Lynette. I think it's really interesting how there is an impact on both of these efforts. Well, they're intertwined, of course, but on population health and on surveillance with the advent of meaningful use and progress that our state and, of course, others have made toward meaningful use. We've seen more electronic access to this type of data. I'd love to hear your perspectives on what the timeline looks like to be able to optimize electronic access to the data that's most meaningful in both of your efforts. When will we be there where we're not looking at phone surveys and registries and it's 20 different sources of data to be able to do the type of work you're doing? And I'll throw it to Lynette first.
Well, the general number I've thrown out kind of over the last couple of years is a 10-year time frame. In watching a number of the automation efforts that we've been doing kind of within some of the areas I've worked, it seems like it takes about 5 years to really get things adopted and about 5 years to figure out how to use them. And that's from the big global perspective, not the day-to-day, not the individual. I mean, and part of that is because you have your early adopters and you have your late adopters, and you have the folks in the middle. And there's also just that really significant business process re-engineering, redesign that happens when you introduce technology. And it starts from when people go through training. How well do they get trained? Where are your champions? How much is it endorsed? And so the adoption of technology takes time. The incentive program, the High-Tech Act, it's pushing us hard for about 4 or 5 years. It is a drop in the bucket. It's pushing hard on getting a at least from the EHR incentive perspective, a relatively small percentage of providers on EHRs. The trick, though, is once they adopt an EHR, a group, a clinic, a facility isn't going to do it for just those providers that are eligible for an incentive payment. They're going to do it for the whole group. And so that's where this incentive program is pushing the boundary and helping us push the edge. So that's happening. So one of the aspects about getting the data to be able to really do the population look requires that there be a level of EHR adoption that you really have a population view. Otherwise, when you start looking at the population data, you're going to have a certain level of bias just because of who adopted the EHR. So over the next 10 years or so, this transition is happening. We're going to have to support both paper and electronic. We're going to have both going on. But I think after about 10 years, so when we get into the 2020s, the norm is going to be the technology, and then it'll be refining how we use that and what the data looks like. The exciting part from a data geek perspective, right now though, is this is when the systems are being built. So what is the data we need to have? How do we need to capture it so that we can actually do that look? And a lot of, I think, what's happening from both the public health population incidence prevalence side as well as from the healthcare delivery quality improvement side is what is the data we should be looking at to really get a read on how it's going. We've done things because that's what we could do. What could we do if it was really captured electronically? So we're starting to see that, and the fact that the EHR is being required to collect things like BMI. Well, right now the only way we know about obesity prevalence is through a telephone survey. As we start to have EHRs adopted and they collect BMI as a meaningful use measure, what does that start to look like if we start to have a data feed from a population perspective to look at incidence and prevalence? It changes it. So, but the data is only as good as the kind of the whole, garbage in, garbage out motto. But you have to think about the bias, the sampling. What is that influence in terms of who your early adopters are versus your late adopters and the different populations they serve. So it's going to be a transition, but it's an exciting transition, and to start to look at what is possible because we've never known that before.
And Taha?
So a few things to, can you guys hear me? A few things to consider. I mean, part of, in our experience, over the last 2 years, we've been building towards that vision about all the different data streams coming from the electronic health records or the automation of healthcare records can flow into one information, and then multiple party can really act around it. We're getting closer. I think we're doing really good with regards, for example, electronic lab reporting or immunization or syndromic surveillance, but there's a lot more to it than just that. Now, some of the challenges is that we face, for example, when we're trying to do replicate this model for what we've done in Maine nationwide, is the measures that, these are CMS measures that follow the National Quality Forum. Everyone agrees what blood pressure means and how to calculate it. On the ground, it's calculated very differently. So the HIEs, one HIE is calculated one way, another HIE is calculated another way, so it's really hard to sort of get that consensus. Yes, we pay a lot of attention to standards of how you share the messages electronically, whatnot, but to kind of put really more pressure on managing the quality and the quality measures that we have and how these measures are happening, that can take a few years to come. Now, having said all of that, is we also need to realize from the population health level, what can you get from EHRs and what you can't get from EHRs. For example, if you're investigating an outbreak, your doctor's not going to ask you, did you eat tomato, but you didn't eat beef, or did you have this, but you didn't have that. So this is why we'll still need to have some of those surveys. One colleague of mine from Boston said, about electronic health records, they provide about 20% of the data they need. But there's still need a lot more data and investigations and different kind of things that need to happen from a public health perspective to do that. But it's nonetheless is a really wonderful opportunity. I believe meaningful use is providing a lot of focus there. But it's a concerted effort. I mean, yeah.
Question from the audience? I have one more. Do we have one more moment? And I'm holding my phone to check to see what time it is, and obviously our phones are extensions of our bodies and our health nowadays. And just wondering if you had a perspective on how PHRs may be used or how mobile may be used to provide valid or trustable data.
I think that's something that's a very hot topic right now, and a lot of folks are talking about it. But given the way digital certificates work, the ability to lock documents, to the extent that the phone is a storage device, and to the extent that people keep their phone close to them and try to hard not to lose them, it is a potential avenue for transferring certain kinds of information. Especially, I mentioned the social history, family history type stuff that we do over and over again. The other piece, though, around that is I think that's really important. At the same time that we look at how we leverage the mobile devices, and that there's huge opportunity there, to keep in mind that many of our vulnerable populations don't have them. So one of the challenges, actually, like that we were just talking about recently, kind of thinking about our Medi-Cal population, there's a lot of folks that will get a phone and they'll have a phone for a month or a couple days or 2 weeks, and then they swap it out for something else because it depends on when the paycheck came in and how many minutes they could buy, and the phone number may not stay consistent. So there's populations where it may be very beneficial, and there's other populations where it's not going to work. So we need to be sensitive to that from a disparity perspective as well, in terms of how we move forward. But there's definitely some huge potential for huge sectors.
Taha, did you want to speak to that?
Yeah, I mean, some of the things that we've been playing with, for example, provide some knowledge back to decision makers. For example, if there's the allergies on the rise, be able to provide that to the providers so that can be pushed back to the patients. Or if I'm a patient asthmatic, is this the right time for me to go outside and run, for example? I mean, so some of those are happening. I mean, definitely the mobile is key to and push that to the consumer rather than the other way around. But there's also need to be quite a bit of attention, which I haven't seen much around, is the privacy for the use of information on a mobile device, and that's sort of is quite a bit of work there too.
Thank you so much to Dr. Kass-Hout and to Dr. Scott.